learning online and teaching everything online. And the recorded sessions, you have all these videos recorded, and these videos are of very good quality. And they're very crisp and concise, and whatever that is needed for your exam is in there, right? And you also have notes. These notes are based on the recent CBME curriculum, and we offer you MCQs as well. These MCQs are, I would say, are very useful for your upcoming next examination, where there's a lot of integrated learning going on, and these MCQs will definitely help a lot. You can also book a slot for personalized counseling session with us, where you'll be given a mentor and who will analyze your strengths and weakness and where you lack, what you lack. They'll be like a friend to you. You can share any concern with them, academic or otherwise. We also, offer 3 different subscription plans. In the basic plan, we have pre-recorded sessions, live class, live quick revision examination modules, basically like the revision course. And in the standard module, we have pre-recorded sessions, live classes, live doubt clarification, quick revision examination. But in the premium is like all in one, where you get personalized guidance as well. You can use my code Dr. Sushma 20 for any additional discounts on the subscriptions, right? This is the tentative schedule we have, and today we are in CVS development. In another 2 classes, we'll do GIT development, which are very interesting, by the way, to learn all the midgut rotations and everything. And then we'll be ending with genitourinary system. So yes, in today's class, we are studying about development of heart. Guys, in the development of heart, for you, what is the most important topic is knowing how interatrial septum is formed. Right? This should be the focus of your study. Everything else is important, of course, formation of heart tube and everything, but how the interatrial septum is formed, that's where majority of the questions are framed. Okay. Quick recap: in yesterday's class, we saw how development of face and palate takes place, right? Before that, we saw all the derivatives of the pharyngeal arches. And in yesterday's class, we learned how the development of the face actually takes place, right? We have the medial nasal septum, which comes like this, then the maxillary comes like this from the side, and they all fuse in the midline. Mandibular forms the lower lip. Very simple, easy. And pharyngeal arches, we've already studied different arteries, nerves, muscles, ligaments, and everything. So in today's class, which is unrelated to the things that we had studied, because pharyngeal arches and face development were closely interlinked. Heart is, of course, it is embryology itself, but you will not see many terminologies related to pharyngeal arches as such, right? Now, here again, as I'm saying, I'm focusing more on the development of the interatrial septum. All right? Yes. Let's just look at a clinical case scenario. Guys, development of heart, if I have to tell you, you see in pediatrics, there is a separate section to study the anomalies, because there are so many congenital anomalies, right? And all of these is of extremely important to you clinically as well, to pick up the signs and to pick up what spectrum of disease does it belong to. Okay, if possible, towards the end, I'll teach you how to approach a case, how the approach to a case of congenital heart defect. Okay, next, a newborn presents with signs of heart failure shortly after birth. Okay, on examination, there is a harsh hollow systolic murmur which is heard best at the left lower sternal border, and there is a loud S3 which is appreciated. Chest X-ray shows there is cardiomegaly and pulmonary congestion. This is the buzzword here, guys, because when you're approaching CVS cardiology, when you're congenital defects in heart, the main question is whether there is pulmonary congestion, or there is pulmonary oligemia. So this dictates how you are going to approach the question. Here there is pulmonary congestion. What does that mean? That means more blood is reaching the lungs. That is why I'm having pulmonary congestion. So this looks like a acyanotic disease. Okay, acyanotic disease with pulmonary plethora. Okay, I know this is a little high level stuff, but this is how you need to approach whether it is pulmonary congestion, or there is pulmonary oligemia where there is no pulmonary congestion present, Right. Given the clinical case scenario, the baby is having a holosystolic murmur. There is a continuous murmur. But the murmur that is mentioned over here is, it is not a continuous machinery murmur. So I can clearly rule out patent ductus arteriosus. But looking at other, other clinical symptoms, I can say this goes in favor of the ventricular septal defect. So overall, how do you, approach these cases is whether it is acyanotic or cyanotic. In the acyanotic, whether there is pulmonary plethora or oligemia. If it is pulmonary plethora, like, for example, pulmonary congestion is present, the DD becomes VSD, patent ductus arteriosus, and of course, endocardial cushion defects. But looking at the clinical case scenario here, I can say that this is answer is VSD. It's a little higher level question, clinical question, interesting question. It's a PG level question actually. All right, let's look at the development of heart. Now, in early pre-somite embryo, the first identifiable cardiac progenitor cell clusters are arranged in the anterior lateral plate mesoderm on both sides of the embryo's central axis. Okay, so what exactly am I saying? Just a second, guys. Something's falling down. All right. So in early pre-somite embryo, like the somites are not yet formed, and the first identifiable progenitor cell cluster is the cardiac cell, right? In the anterior lateral plate mesoderm. So where is the lateral plate mesoderm present for us? Where is the lateral plate mesoderm present for us? This is the midline. Here I have the lateral plate mesoderm. Then here I have the intermediate mesoderm. And towards the last, I have lateral plate. Towards the last, I have lateral plate mesoderm. So what is this? This is paraaxial mesoderm, intermediate mesoderm. This is lateral plate mesoderm, correct? The lateral plate mesoderm on both sides of the embryo's central axis, these clusters, they form the paired cardiac tubes, right? If you write it like this, and these are the structures which form the paired cardiac tubes by 18 days of gestation. It is just 18 days, guys. In yesterday's class, or in day before yesterday, as we were talking, the pharyngeal arches and everything, they were all developing after between 3 to 8 weeks, isn't it? Now we are talking about 22nd day. That means we are still in the 3rd to 4th week of development. Then these paired tubes, they fuse in the midline on the ventral surface of the embryo to form the primitive heart tube. Why on ventral surface, guys? I keep repeating this. All of the events that you observe, by rule, they all happens in the ventral surface of embryo, because the development is craniocaudal. You will never hear something has fused in the caudal and in the beginning. You will always hear the paired tubes fuse in the midline of the ventral surface of the embryo, right? Next, this straight heart tube is composed of different layers. Like there is outer myocardial layer, inner endocardium, and the middle extracellular matrix, which is called as cardiac jelly. That is called as cardiac jelly. Okay, this is what I'm talking about. This is how the heart tubes are formed, right? And then they have begun to fuse. Look at the development. Look at the arrow here. What is this? This is craniocaudal. The arrow is craniocaudal, and the fusion of the endothelial heart tube is almost complete, and single primitive heart tube is now formed, right? Yes. Now, there are two distinct cell lineages which provide the precursor cells for the left ventricle, whereas secondary heart field provides precursors for right ventricle and atria. Not very important for you, right? Just know that we have pre-myocardial cells, that includes the epicardial cells and cells derived from the neural crest that continue their migration into the region of the heart tube. See, I keep mentioning, guys, neural crest cells are very, very important. They are indeed referred to as the fourth germ layer, because you have contribution from neural crest cells almost in every organ, isn't it? In the phase also, we studied how neural crest cells contribute. Is it or is it not? Are you remembering the big list that I gave you, the derivatives of the neural crest cells, right? What does it not form? Spinal cord and adrenal medulla. Yes. Next, the regulation of this early phase of cardiac morphogenesis controlled partly by the interaction of There are certain signaling molecules, guys, here, which you may not want to remember, but just know that there are certain signaling molecules and ligands which are responsible for this. There is a signal which comes. Let's look at it this way. Simple concept. There is a signal that comes and tells the cells to migrate and contribute. Okay, understanding? Yes. Next, positional information is conveyed to the developing cardiac mesoderm by factors such as retinoids. What are retinoids? These are isoforms of vitamin A which bind to specific nuclear receptors and regulate the gene expression. Okay, this. Further, the migration of the epithelial cells into the developing heart tube is directed by extracellular matrix proteins such as fibronectin, integrins, and BMP2. Just know that these are all the different signals. Like we have retinoids, we have fibronectin, we have integrins, we have BMP2. So all of these different molecules, they signal for the development of heart. Okay. Now, the clinical importance of these ligands is actually revealed by cardiac teratogenic effects caused by the retinoid-like drug isotretinoin. What happens, guys? You can see over here, isotretinoin is a factor that actually is cardiotoxic. Why is it cardiotoxic? Why, when a patient takes isotretinoin as a treatment, let's say for any dermatological condition like acne and so on and so forth, you advise the women to not to get pregnant, or rather it is contraindicated in pregnancy, even though it stimulates collagen formation and it is good for your skin and everything. But isotretinoin as a drug is contraindicated in pregnancy. Why? Look at the answer. Because retinoid is a signal, it gives a signal to the development of heart. And what is that signal? The positional information. Positional information, where exactly the heart should be situated and where exactly the heart should develop. Where is this information coming from? Who is giving the signal? Who is the signal transducer here? It is the retinoid. And also we have other things like fibroblasts, integrins, BMP2, so on and so forth. But understand, guys, that is the reason why certain drugs are contraindicated in pregnancy. There's a huge list, like you will not give ciprofloxacin, and in pregnancy, let's say you don't give anything like all the anti-epileptic drugs like phenytoin is contraindicated. Why? It causes fetal hydantoin syndrome. Similarly, isotretinoin, why is it contraindicated in pregnancy? It is because of this. Look how whatever you're studying right now in embryology, a very simple topic like development of heart has such a huge implication. When you try to look at medicine from an overview, bird's eye view, if you see what you study in anatomy, the basics that you have is what is going to determine the kind of clinician you become. You should know why isotretinoin is not given in pregnancy. Okay, I'll tell you guys, if you master your first year subjects, let's say like biochemistry, anatomy, physiology, you'll become a very good clinician. You'll become a really good clinician. Okay, if your basics are not strong, if you don't know what FeV1 by FVC is, you may know that the ratio when decreases it's obstructive, increases it's restrictive. You may know the definition, but you should know what FeV1 by FVC actually is. Right? If you don't know the basics in physiology, if you don't know the flow volume curves, if you don't know the spirometry, you will not even understand the pathophysiology of asthma. You will not even understand how to diagnose asthma. So similarly, please pay attention to your first year subjects. They're very, very important, not just there to pass you and push you to the second year, right? Yeah. Now, isotretinoin, that is why it's not indicated in pregnancy. Now, as early as 20 to 22 days before the cardiac looping, the embryonic heart begins to contract and exhibit phases of cardiac cycle. That is why at about 6 weeks itself, you can actually see the fetal heart beating, plup, 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 that you can see. Okay. At by 20 to 22 days itself, you can see this contractions. All right. Then as the development of heart is much faster as compared to other organs because it needs to keep the embryo viable, right? Now, certain anatomists, they actually identify the segments of the heart tube and that were believed to correspond to the structures in the mature heart. Like, for example, sinus venosus. right? And atrium. Sinus venosus forms the ventricles. Primitive ventricle, bulbous cordis, truncus arteriosus, which forms the aorta and pulmonary artery. So they have identified all this at 20 to 22 days itself. Okay. And if you look at the heart tube, the tube that I told you how in the lateral plate mesoderm, the tubes are formed and they come closer and they fuse with each other. This is how the fusion looks like. These are the different areas. The first one you have is the truncus arteriosus, arterial end. Then you have the bulbous cordis. Then you have the primitive ventricle. Then you have the primitive atrium. Then you have the sinus venosus. Look at this. Look at this diagram, guys. If you look at the human heart, this is how it is, right? This is how it is. Atria is above, ventricles are below. But look at the embryology. In this picture, ventricles are above, atrium is below. Why is it like this? Why is it happening like this? Now, how will atria go above and ventricles come below? It happens by a process called as cardiac looping. It happens by a process called as cardiac looping. Okay, approximately at 2 to 24 days, the heart tube begins to bend ventrally like this towards the right side. See, tube is like this, it starts bending like this. Tube is like this, where atria is supposed to be on the top and ventricles are supposed to be in the bottom. But what is happening in the embryology? If you look at the tube, here you have just look at this diagram. Uppermost, you have the ascending aorta on the pulmonary trunk, and then you have the outflow tracts for the right and left ventricle, then the right ventricle, then the left ventricle, then the primitive atrium, which forms atria, and then the sinus venosus. But if you look at adult heart, atria is actually present on the upper side and ventricles are on the lower side. How does this happen? It happens by looping, because the heart tube begins to bend ventrally like this and towards the right side. So that what has happened? If this is the ventricular end and this is my right, this is my left, correct? Tube is like this. This upper portion is what? Upper portion is the ventricular end, aorta and interventricular passage and everything. Below that, I have atrium, correct? Atrium and the sinus venosus, and all of this is present. Primitive atria, sinus venosus and everything. Now, the heart tube starts bending ventrally and towards the right. Okay, as it starts bending towards the right, now what has happened? All of the ventricles and everything have come leftward, whereas the right ventricle is shifted rightward and in continuity with the truncus arteriosus. Is it or is it not? This is how, because of the cardiac looping, we have this rearrangement of chambers. This is how, look, this is how it happens. You can see because of the looping that happens, we have rearrangement of chambers. Okay, just to summarize what different parts form the adult derivatives. We have truncus arteriosus giving rise to ascending aorta, pulmonary trunk, bulbous cordis, smooth upper part of the right ventricle and the smooth upper part of left ventricle. Bulbous cordis is mainly the ventricles. Then primitive ventricle, trabeculated part of right and left ventricle. Primitive atrium, right and left atrium. Sinus venosus, smooth part of the right atrium. Coronary sinus and oblique vein of the left atrium. Okay, this list is important. This list is very important. You may not understand how. I hope you've understood how, because of the looping like this, because of the formation of a loop like this, how there is rearrangement of structures. But this list is actually very important for us. Okay, this is a concept of cardiac loop. As you can see how the looping has taken place like this. Basically, it comes like this. That's why the right side goes up and the left comes down, and atria is up and the ventricles are down. Okay. Now, what signals to this cardiac looping is differential growth rates for myocytes on the convex versus concave side of the curve. And there is some cell death and other so many mechanisms, so many signal factors that are responsible for this. Okay. Yes. Now, what are the different signaling pathways that have been identified for this left to right asymmetry is some SHH, transforming growth factor, beta, nodal, and LR, dynein. These are the some signal pathways, and anything that blocks these signal pathways will block all of these mechanisms, and there will be death of the fetus. Okay. Yes. Look at this, guys. This is how the primitive blood vessels, and this is the cardiogenic area. As you can see, the primitive streak will form over here. Notocard will form over here, and this is the cardiogenic area. And here you have the, what do we have here? The one that is not covered by the mesoderm. Buccopharyngeal membrane, this is cloacal membrane. Correct? This is how it is formed. And you can see the cardiac tubes which are formed, and they are fused together in the midline. Then that is forming this bulbous cordis, primitive ventricle, truncus arteriosus, primitive atrium. Now the coiling, the looping is taking place like this, because of which we have rearrangement of the chambers. And finally, towards 35 days or at around 7 weeks, you have the formation of this. So that is why 6 to 7 weeks, you have a heart that is formed, which is beating. Radiologically also, you can see this, right? Truncus arteriosus, left atrium, ventricle, all of this is formed. What is the role of neural crest cells in the cardiovascular development? Heart chambers, coronary arteries, contribution to septum, formation of great vessels. It is actually formation of heart chambers. Let's look at the cardiac septations. Okay. When I talk about cardiac septations, what do we have? We have two things. One is the intra-atrial. Okay. We have the cardiac septation. When the looping is complete, the external appearance of the heart is similar to that of the mature heart, as you can see here in this diagram. Look at this particular picture, right? It looks the same, but internally it is still a single tube. How does the mature heart look like? We have interventricular septum, interatrial septum, and then we have valves also here. And there is aorta, and there is pulmonic artery. All of these are coming, isn't it? Now, the common atrium, which is comprising of both left and atria, is connected to the primitive ventricle, which is the future left ventricle, via the atrioventricular canal. Now, the primitive ventricle is connected to the bulbous cordis, which forms the future right ventricle via bulboventricular foramen. Correct? Now, the distal portion of the bulbous cordis is connected to the truncus arteriosus via an outlet segment. Now the heart tube consists of several layers of myocardium and single layers of endocardium, which is separated by the cardiac jelly in between and acellular and extracellular matrix. Septation actually begins by day 26 with the ingrowth of large tissue masses, which are called as endocardial cushions. Very, very important at both atrioventricular and conotruncal defect. There actually, there's a, what is this? Sorry, I just forgot the name. It's a bulbous cordis. This is a bulbous cordis. They're all developing here. The endocardial cushions are developing here. Okay. Now, endocardial cushions are very, very important in the formation of the septums. Okay. Just know the name endocardial cushion. Further, they de-differentiate and migrate into the region of the endocardial cushions, eventually becoming mesenchymal cells that forms the AV valves. Okay. Yes. Don't worry too much about this. Right. I've added all of these things just for the sake of completion. But actually, what you're supposed to know is the formation of interatrial septum. In these slides, I've only taught what these endocardial cushions are. That's it. That's all you need to know. There are something called as endocardial cushions which are present. Okay, that's all you need to know. You don't have to know how and why and everything. Now let us understand the formation of the interatrial septum, and this is where you have maximum questions come. Now, to understand that, first let's look at the basic anatomy, right? Here I have the septum primum, which is coming and it is developing the interatrial septum. Here I have the endocardial cushions that I was talking about. Okay, this is the basic anatomy. And now heart is just a tube like this. It's just a tube where there is, movement of blood. Remember guys, in heart, I need right to left shunt. Okay, I need the blood to move from right side to left side. From the left atrium, it should go to the left ventricle. Correct? It should go to the left ventricle, and I don't have the blood coming in from the lungs to the left atrium because lungs are not developed yet. This circulation establishes only after birth. All of us know this. Now, look at this, what happens. Septum primum starts developing and it starts coming downwards and downwards and downwards and downwards, and it reaches till here. Okay, it has come down and it has reached till here. And the foramen that is formed, septum primum, let's say, has come till here and it has reached till here. And initially, the first foramen that is formed over here is called as foramen primum. Foramen primum. This is the first development that happens, the first foramen that is formed. Then what happens if this is the developing atria, and I have the foramen, I have the septum primum which has come over here and it has reached till here, and the foramen primum got formed. Now it got fused with endocardial defects. Okay, it has reached till the endocardial defects and it got fused with it. After the fusion, what happens is the septum primum starts to disintegrate. The septum primum starts to disintegrate, because of which I have endocardial cushion here. And then some amount of septum primum is left here. Because of here, I have one more foramen formed over here, which is called as foramen secundum. After the foramen secundum gets formed, one more septum starts developing lateral to the foramen secundum, which is called as septum secundum. Septum secundum. Now, the blood always moves from right side to left side in heart. Now, I can clearly see if the blood has to move from right atrium to the left atrium, it has to pass through like this in an oblique way. Now the foramen that is formed over here is called as foramen ovale. Understanding? Foramen ovale. Because the septum secundum is formed, there is no two-way movement of blood. Okay, let us say I have the septum this is the primum which is formed like this, right? And here I have the septum primum and here I have the septum secundum which is formed, and the blood will have to move like this. The blood cannot enter because now these two septum prima which are there are preventing the blood to enter from left to right atria. Understanding? So just to summarize whatever we have learned, let me just write it in a new slide. Now what has happened? Initially, I had septum primum between my two atria, right? This is the one chamber that I had. There is no right and left differentiation, but septum primum formed like this, which is the initial one, right? After the septum primum formed, it started moving towards the endocardial cushions. Okay, and here let's say are the ventricles, endocardial cushions. Started moving towards the endocardial cushions, but it stopped in the midway to form the first foramen, which is called as foramen primum, the one that is formed first. After this, again it started moving. After this, again it started moving and it has joined the endocardial cushion defect. Now after its joining, it starts to disintegrate. And once it disintegrates, it forms a new septum. It forms a new foramen, which is called as foramen secundum. After the foramen secundum is formed, there is a new septum that is formed in the atria, which is called as septum secundum. After the formation of the septum secundum, now I have something like this. This is the formation of the septum secundum. Now, whatever the blood that I have will have to go through this in an oblique pathway. Okay, we'll have to go through like this, obliquely. Now, the foramen that is formed is called as, through which the blood is passing through in an oblique way, is called as foramen ovale. So, in what order are the foramina forming? You have foramen primum, ostium primum, whatever you can call it. Then you have secundum. Then you have ovale. This is the order in which the foramen are forming. Later, after the child is born, after it takes few breaths, the pressures in the lungs come down, the blood starts to enter the heart. Okay, the blood starts to enter the heart. Once the blood starts entering the heart, let's say the from the lungs we have the blood which is coming over here. Because of this is the because of this, let's say the foramen secundum and the foramen, sorry, the septum secundum and the septum primum, they fuse together and then they seal the defect of foramen ovale. If foramen ovale, the defect is not sealed, let's say this is, what is this? Let's say the blue one is the blue one is the septum secundum and the red one is the septum primum. After birth, when the blood comes, they both seal. Afterwards, when the blood comes, they both seal. Okay. Once they seal, what happens? The foramen closes. If they do not seal, it causes what is called as patent foramen ovale. All right. The first ostium that forms is the ostium primum. Then we have the ostium secundum, which is formed. The second opening that is formed is this ostium secundum, right? Then we have the last is the foramen ovale, which gets closed after the birth. And the non-closure of foramen ovale causes patent foramen ovale. This is the concept. The take-home message of today's class is this. This is the concept that you have to learn. Okay. Two things are important here. Number one is the formation of the heart tube and the looping of the heart tube. Number two is this, whatever I have taught. The order, septum primum comes. Then the first ostium that is formed is foramen primum or primum ostium primum. And then it fuses with the endocardial cushion. There is disintegration in the septum primum. Then a new foramina formed, which is called foramen secundum. After foramen secundum formed, there is one more primer, septum secundum coming down like this. Then what happens? The blood will have to move in an oblique fashion, resulting in the formation of the foramen ovale, which acts as a one-way valve so that the blood is not shunting from the left side. Shunting from the left to right atrium is now blocked. After the baby is born, the baby takes breath, the pressure decreases, the blood enters the lung, and then the lungs also bring back the blood. Then what happens? As the blood enters the left atrium, the foramen ovale closes. What are the two septums that are joining together to close it? Septum secundum and septum primum. Very, very important concept, guys. This is exactly what is asked in your examinations, in your UG examination. Okay. Now, formation of interventricular septum begins at about day 25. Not very important, guys. This is not very important. You should know this, when it comes to understanding the blood supply of heart, which is again a very complicated thing. How the venous system develops is a very complicated thing. I'm not getting into that, but for you, it's not very important, right? Three parts. There is muscular part, bulbar part, and membranous part. Okay. Then interventricular septum. This is the events that are formed. Just one more thing that I forgot to tell you, which is that the chromosomal disorder, chromosomal abnormality that causes endocardial cushion defects. Okay, I am talking about endocardial cushion defects now, the ones that are present here. Which is that chromosomal abnormality that causes endocardial cushion defects, guys? Is Downs. Downs, what is it? 21 trisomy, which is causing due to the non-disjunction of the maternal chromosomes, right? Remembering anything? Remembering, or you should be able to correlate all of this together now. Downs, what do we see? We see simian creases, there is mongoloid features, and there is endocardial cushion defects. Anything ringing in your head? Non-disjunction of the 21st chromosome, right? Yes, that Down syndrome only I'm talking about, where there is endocardial cushion defects. Okay, next, development of the heart valves. There are two in number, atrioventricular valves, and what are the two we have? Atrioventricular and what else? With pulmonic and aortic valves, right? Tricuspid and mitral valves, which are formed by the subendocardial mesenchymal proliferation, and they project into the AV canal as swellings. Again, not very important for you guys. Just for the sake of completion, I've added all this. Free margin of the ventricular surface of the valves connected to papillary muscle through chordae tendineae. Next, let's just take a few MCQs. The following structures contributes to the formation of interatrial septum. Septum primum, secundum, endocardial cushion, neural crystals. Mainly the septum primum. Even though septum, secundum and endocardial cushions do take part, but it is mainly the septum primum that comes down like this and reaches the endocardial cushion, and then the septum secundum develops. So what is the order in which foramen is formed? Ostium primum, foramen secundum, then foramen ovale is formed. Okay, this order is very important, guys. This will be asked in your examination. You cannot afford to get it wrong. Next, pulmonary and aortic valve, they develop from the endocardial cushions that are formed at the junction of truncus and conus. Again, don't go in detail. It's not required for you. Conducting system of the heart, we have SA node, AV node, bundle of His and Purkinje fibers. SA node develops during the 5th week of IUL, intrauterine life. Initially, it is located in the right wall of the sinus venosus, but when the sinus venosus is absorbed, that is when the looping takes place, what happens? Right atrium, then it comes to lie in the wall of the right atrium near the opening of the superior vena cava. This is where SVC opens. Here you have the SA node. Have the SA node. Okay. AV node and bundle of His, again, they are derived from the cells in the left wall of the sinus venosus and AV canal. All right. Purkinje fibers, they are arising from the AV bundle pass from the atrium into the ventricle, split into right and left bundle branches. We all know this, right? Next, aortic arch development. Basically, aortic arch, head and neck vessels, and the pulmonary, proximal pulmonary arteries and ductus arteriosus, they all develop from the aortic sac, arterial or arches, and dorsal aortae. Okay, when the straight heart tube develops, the distal outflow portion bifurcates into the right and left first aortic arches which join the paired dorsal aortae. Not so important for you guys, right? For all you need to know regarding the arterial system is what is the first aortic arch giving rise to? What is the second aortic arch giving rise to? How the aortic arch is formed? It in itself is a very big topic. All you need to know is first and the second arches largely regress by about 22 days, but the first aortic arch gives rise to maxillary artery. Is it not coinciding with the first pharyngeal arch, guys? Second gives rise to stapedial and hyoidal arteries. First pharyngeal artery arch is also maxillary artery only. Is it or is it not? Mandibular nerve and maxillary artery. The third arch participate in the formation of innominate artery and common in the internal carotid artery. This is very important. ICA and the common carotid artery is coming from the third aortic arch. That's all you need to know. Fourth arch gives rise to subclavian artery, right subclavian artery. Left fourth arch participates in the formation of segment of the aortic arch between the left carotid artery and ductus arteriosus. Fifth arch does not persist. Just like how the pharyngeal arches are there, just know what are the arteries of the different arch, and it coincides with the pharyngeal arches. Okay. Now the sixth arch join more distally and it gives rise to right pulmonary artery, left gives rise to ductus arteriosus. Okay, this is the development. These are the different arches that are formed. Okay, understanding? Yes. In this is what is important source of development of main arteries. Just know which arch gives rise to which artery. Don't go in detail about all of these things. It's not really necessary for your level. What is necessary for your level is number one, knowing about cardiac looping, how the bending takes place so that there is rearrangement of chambers. Number two, we should know about the interatrial septum formation, which is very important. That's where question comes from. Number three, knowing about aortic arches, just little introduction of aortic arches and corresponding arteries. This is all you need to take away from today's class. If you know that much, more than enough for you. All right, that's it. From first, second, third, these are the 3 points you will have to know. Okay, let's just finish the class with a couple of MCQs. Which of the following structures primarily contributes to the formation of heart during embryonic development? Undoubtedly mesoderm. Why? Because it is forming in the lateral plate mesoderm. The heart tube itself is forming in the lateral plate mesoderm. There's nothing called as exoderm. Exoderm, I think, is that some dishwashing thing, na? Exoderm, I don't know. Then at which week of embryonic development does the heart start to beat? Generally 5 to 6. Let's say we can mark 6 for this question. Okay, understood? Very simple and easy class. Three important things. Number one, looping. Number two, development of interatrial septum. Foramen, that one in sequence, and the septum, what different septa are there? That is number two. Number three, aortic arch and corresponding arteries. That's it. If you remember this much, your development of CVS is sorted. Okay. Thank you so much, guys. Thanks for watching, and I hope you enjoyed today's class. And I'll see you tomorrow with another interesting class. Midline, development of GIT is very interesting. All the best. Good night, guys. Thank you.